So thanks for joining us. We are in the home stretch of this particular series. A reminder not to disclose any PHI in our case studies. Next slide. Here's our usual information about contact information. You can contact Rick or Claire or me at any point. And some general information about cardio, which you've seen before. Next slide. So today, Chris is going to talk about guidelines. And Chris, I don't want to steal your thunder, but Chris has been selected to serve on the upcoming Dietary Guidelines Advisory Committee, which is a very prestigious honor. And people sometimes say, well, what's the point of dietary guidelines if people don't follow them? But those guidelines actually have a great deal of influence, for example, on school lunches and WIC programs and other supplemental eating food programs as well. So congratulations to Chris as far as that goes. Today, one of our case presenters was not able to make it, so I will be presenting a single case, which is not such a bad thing because we'll have some extra time to discuss it. And I've asked both Danette and Adam to comment about it. So next slide. Here are our usual disclosure statements. I don't believe there are any changes. Next slide, please. Okay, Chris, take it away.
All right. Thanks, and I appreciate the acknowledgement, Dr. Rao. It's been a time of ramping up the dietary guidelines, which has been a very interesting insight into the process and the science and how much the science really plays a role. And I'm going to focus a lot today on the U.S. dietary guidelines because they spend a lot of foundation of how a lot of the other dietary recommendations are built. So our objectives for the talk today. And looking at the diet, so different sources of the dietary guidance that we use for making nutrition recommendations. As we mentioned, we have the U.S. dietary guidelines that creates this evidence-based approach to what is healthy eating, which we'll discuss a little bit more in detail. But as well, the professional associations have developed their nutritional recommendations specific for chronic conditions. So the American Heart Association has their dietary recommendations that are very specific to cardiovascular disease risk and hypertension. Whereas the American Diabetes Association is going to have their dietary recommendations be much more specific to glucose metabolism and maintaining hyperglycemia and comorbidities from diabetes. So they're going to have a lot of those same central tenets that will fit overarching diet quality, but with a penchant towards addressing specific concerns within those target groups. And then we see comments and discussions about the DASH diet, which was developed for hypertension, and the Mediterranean diet, and many other kind of dietary patterns that follow along this line. But what you're ultimately seeing is a consistent theme across whatever the focus is increasing fruit and vegetable intake, increasing whole grain intake, reducing saturated fat, limiting added sugar intake, and choosing a variety of foods. So regardless of which of these plans you're really kind of looking at, and this is something that Jim really talked about with the plant-based diets before, plant-based is essentially the underpinning of so many of these recommendations. It's the ensuring that you're getting dietary variety, getting your fruits and vegetables, consuming your whole grains, and then building your dietary pattern off of that as a foundation. So it's a lot of different names, but with many of those same kind of themes carrying throughout. So the U.S. dietary guidelines are what represent the latest evidence-based healthy eating recommendations within the U.S. They're by law, they are updated every 5 years. The latest release that came out was the 2020 to 2025 dietary guidelines. And we're in the process now of developing the 2025 to 2030 guidelines. The recording from the first meeting is available to see up on dietaryguidelines.gov. The recording from that first meeting really sets the stage for what what the questions are, what the public priorities were, and how this will then inform the work that will be happening over the next 2 years. But as Dr. Rao mentioned, they established not only just what our recommended definition of a healthy diet is, but it underpins so many of the federal programs, SNAP education, WIC, National School Lunch, aging, adult meal programs. All of these programs rely on the dietary guidelines for federal food assistance programs around defining what healthy eating is. So the process for creating the dietary guidelines has evolved. The process that has been adopted for this time around is that the scientific questions were developed and put out for public comment. And then once the questions were established, then there were nominations submitted to the 4 members to be on the Dietary Guidelines Advisory Committee. Those nominations were reviewed, the committee was appointed. We've refined the questions, and then we're on the stage of reviewing the scientific evidence. And this data comes from not only the published evidence that exists around different topics, and with a focus specifically on prospective cohort studies and randomized clinical trials documenting the process, but also food pattern modeling data that looks at what people are consuming and actually assessing the nutritional quality and kind of nutritional diversity of the foods that people are consuming. So it takes a very scientific process, but also a data-driven process to create recommendations that provide the dietary variety that's needed, but also meeting those nutritional needs that we have across all of those nutrients. And that becomes a very complex question of making recommendations around different types of dietary patterns, but also ensuring that if we're trying to restrict calories for weight management, reducing calories isn't equivocal to nutritional adequacy for vitamin D, for iron, for calcium, etc. The other thing that has been a strong theme across this set of the dietary guidelines, as they talked about in the public meeting, was really about a focus on health equity as a lens in this. So looking at these scientific questions that come forward, not only from what is the link between saturated fat and heart disease, et cetera, but what is the health equity lens that this brings? So I think this round of the dietary guidelines report from the opening meeting is really going to have a very different kind of look from that. From taking that angle, really trying to put health equity as a lens within this. So the committee will then do their work. They'll develop their scientific report. I have the link to the last scientific report, which I believe was in excess of 850 pages. What that means is it's not a public facing document, but it becomes the scientific summary of those scientific questions that then goes to USDA and Health and Human Services as the committee's basically their recommendations. And then the USDA Center for Nutrition Policy and Promotion then condenses that into a public document, which is the dietary guidelines. So the committee's report is really an overview of the science, whereas the US dietary guidelines are really recommendations. How do we translate that into everyday Americans to promote health and prevent chronic disease? So the committee writes the report, but USDA and HHS work together to develop the dietary guidelines as a document for the public. So the audience for those dietary guidelines are really policymakers, health professionals, and the general public in making healthy decisions. So the four major overarching guidelines that came from the 2020-2025 dietary guidelines was following a healthy diet pattern at every stage of life. If you look through the 2020 to 2025 guidelines, a lot of work was done in the bulk of the work from a lot of those research questions. This is the first time they did birth to 2 years of age. So there's basically a whole cadre of research that needs to be caught up to begin to make recommendations, because before this, the recommendations for 2 years and older. So we really see an introduction of the life stage approach much more in these recent dietary guidelines. Customizing the nutrient dense foods and beverages to personal, cultural, and budgetary considerations. So we're starting to see this infusion a little bit more around making different types of selections and different types of grains, fruits, vegetables, etc. And we're really looking at how do you meet nutrient needs while also staying within caloric recommendations. So caloric recommendations recently, National Academy of Medicine just released their new recommendations for energy. So the estimated energy requirement, dietary reference intakes. So how do we help people meet their nutrient needs while also staying within their calorie levels? And then the final focus area was around limiting foods higher in added sugar, saturated fat, sodium, and limiting alcoholic beverages. So a term that you may have heard is discretionary calories, kind of moving away from this term around discretionary calories, but making those food choices optimal for meeting your nutritional needs. And what we've seen over the past 10 to 15 years is a shift away specifically from meet your nutrient recommendations, eat less saturated fat, eat less sodium, eat more fruits and vegetables, but shifting to much more of a food, of an overall kind of dietary pattern. And from the dietary guidelines, how do we translate this into recommendations for the public? We all kind of remember the food guide pyramid, and what's the most important thing of the pyramid? It's the bottom, not the top. So people kind of got confused. But when they made the transition to my pyramid, which had the active person where you were eating for your activity, the research that they did showed that 80% of people knew that when I saw the pyramid, I knew it was something to do with healthy eating. I wasn't sure what it meant, but I knew it was something to do with healthy eating. So there was some brand recognition with that. But then when they came up with my plate, they were looking at a way to get much better into the proportional distribution. So make half of your plate plant or fruits and vegetables. Make a quarter of your plate grains, a quarter of your plate a protein food. And then this helps us get into this mentality of proportionality. And how much an individual needs, because it used to be eat your 5 fruits and vegetables a day, because that was 2 to 3 fruits per day and 3 to 5 vegetables from the food guide pyramid. And if you ate the minimum, you got 5 a day. And when it went to my plate, it was kind of a cup equivalents and the numbers kind of changed. So now this gives us a much better kind of proportional recommendation that patients can look at their plate and say, all I'm eating is white meals. I've got rice, I've got chicken, I've got potatoes. Now I'm not seeing color variety. How much proportionality am I seeing? And it makes it a little easier to start kind of visualizing the food choices that we make. One, around providing the variety, but also around the quantity and the proportionality. So creating that pathway towards lifestyle behaviors, we're looking at trying to manage many of our chronic conditions chronic conditions between pharmacologic therapies. How do we bring down their blood pressure? How do we bring down their hemoglobin A1C with pharmacologic measures? But at the same time, how do we use lifestyle behaviors to optimize what that treatment strategy is? As I described diabetes, it's an appropriate time in Ohio. It's winter. If your house gets cold, you can turn up the thermostat and you can continue to pump out more heat. But your house isn't going to stay warm if you leave your windows and your back door open. So we can continue to use pharmacologic therapies to manage blood sugar, but if we don't manage how much blood sugar is being produced from the diet, we're basically trying to heat the house with the doors and the windows open. So using lifestyle behaviors as a strategy within the treatment process becomes a really important element, especially around these diet-related chronic diseases. A lot of patients will basically consider, well, I'm taking a medication for my diabetes or my hyperlipidemia, so I don't need to change my behavior because my medication will take care of that. And many of them say that and from our studies that we've done, they said that they knew that this was something that they should do. I should eat healthier, I should do that, but I really like whatever, insert food here. But it was never really a priority for them until their primary care provider directly said, I'm concerned about your diabetes, I'm concerned about your hypertension, and I think you need to change your diet to improve these outcomes. And that was when they really started to take it to heart and start to actually make it an actionable strategy. So in translating those guidelines into food, we have a lot of science, we have a lot of nutrients, we have a lot of various studies that look at individual parts and components. But what we have to do is translate this into patients' everyday realities. We have to translate it into breakfast, lunch, dinner, and into snacks. I always say that snacks become one of those places that everybody just kind of mindlessly eats, but doesn't eat like a meal, but they contribute basically a meal's worth of intakes. So we can make lots of recommendations around eating at meals and things like that, but then we also have other elements that might start to create challenges. And what it means is it's a complex problem. It's a complex behavior that isn't easily solved within a very short conversation. There are a lot of factors that drive what people eat, why they eat, and what foods they have access to. So the U.S. Preventive Services Task Force says that we need medium to high intensity lifestyle interventions to achieve meaningful lifestyle behavior change. So I have generally heard from all of our sessions that this is not how much you typically have to spend with patients on a session by session basis. But what it means is it creates opportunities for reinforcing and activating conversations, and then using other members of the team to then be able to provide some more of that detailed guidance, referring to resources that will help them make decisions, and thinking about staying in your lane as far as your professional lane. What's your scope of practice allow you to do and make recommendations? And who are those that are going to be best suited and best prepared to be able to address those concerns that patients may have? And lifestyle behavior modification really requires taking those recommendations that we have and putting it into that person's life, their life situation. If we're talking about increasing fruits and vegetables in individuals with limited resources, then we're going to have to use different strategies. And food preparation is going to become an important component. Food storage is going to become an important component. So the ways in which they can actualize these behaviors is going to be very dependent on their situation. And a lot of the conversations we've had from the cases have been really looking at ways we can fit these lifestyle behaviors in with their current life situations. And a lot of the recommendations that we look at are really focused on these nutrient intakes or overall food intakes, daily this, consumption of that, eat this, how many fish do you have per week, and how much dark green leafy vegetables do you have in a week, and eat fruit every day. So really helping to translate these ideas of these foods into meals into strategies of what are you doing now and what are things that you can do to make a change to implement these. So how do we take that big picture and get it onto the fork? And that'll be where we'll be most actionable. And finally, really talking about utilizing the team. We've got very complex issues and patients have competing demands. They're trying to balance lots of different priorities in life. And now we're adding nutrition, and their diet quality is one of them. If we're looking at individuals with limited resources, then this becomes not only a competing demand for rent and gas, now food and eating healthier, as well as medications, etc. So looking at ways that we can reach out to the resources that we have, either within the office or within the community, that can help them address those competing demands. And then that helps open the door for the opportunity for them to be successful. So referrals for team-based care have been some of those ways that we've really tried to spread out the opportunities for people with different skill sets to be able to help. For the registered dietitian referrals, we have found an astounding amount of reimbursement, more than any of the administrators have thought, from being able to get patients referred to a dietitian and build to insurance. So exploring the fiscal opportunities within that to make it a viable service. Mental health resources, as we've talked about on many of our sessions, dealing with those challenges and how they're going to influence appetite and health and diet are going to be very important. So as well as food assistance programs or life assistance programs, if we're able to refer out for SNAP benefits to be able to afford food, or food pantries, or rent assistance, or medication assistance, we've now increased the purse size of an individual to be able to make healthier choices. And finally, and I know Jim has talked about this a lot, is the finding their why. Figure out what it is that's really important to them and what's the one thing that they feel like they can change, and start there. We'll hardly ever be able to get them to stop eating their favorite food, but we can work our way down and find places where they feel like they can cut back or make some changes and develop some success, and figure out what it is that they're really looking for and help drive towards that then they can start making changes and see things turning in that aspect of their health and in their life and in their lifestyle, and then use that as a continuing motivator for their change. And with that, I will stop and take any questions.
Thank you, Chris. Any questions for Chris?
Yes, I have a question, Chris. And one of the, I guess, something that keeps coming up for me with changing their diet, let's say like before the bariatric surgery, is cultural traditions in food. Like, even though they clearly have, the My Plate, and they know what that looks like and whatnot, what they struggle with is still how to eat, like, how much beans and rice can I have? And so will the document that's made, well, maybe you don't know the answer to this now, but whatever's made public, I wonder if they could give examples of, this is what a plate will look like if you're from, Hispanic tradition, or, African-American tradition, or you like German food, or, if some specific examples, because people seem to get lost, with still how to eat, even though they see the My Plate,
Yeah, that is, I don't know that I don't have my crystal ball yet, so I'm not sure exactly what things may look like as far as what the recommendations will be. But looking at it in terms of a foundation of plants, and this is kind of goes back to the presentation Jim gave us a couple of weeks ago around being plant-based. I'm less concerned about if they're going to have beans instead of grain instead of this, but looking at it as a foundation of having a plant-based source. If you're looking at it from a fruits, vegetables, and grains, I'm less concerned about a bean being counted as a vegetable or a meat if we've got beans on the plate. And if we're using it as a foundation and as a plant-based kind of staple, we're now getting into much more the point around limiting the sources that are higher in saturated fat, the protein source, taking protein sources that are more plant-based, which fits in with those beans. But now it actually adds some of that latitude to make decisions. And the other thing is, you can't look at a bowl of soup and portion it out, but you can look at a bowl of soup and say, is this a fully meat-based soup, or is this a soup with meat and all sorts of other things in it? And then how does this help me round out to make sure that I'm making a variety of choices rather than a potato, a noodle, and a large piece of meat or that sort? So it helps us really start to re-envision the way that we're creating a plate. And then you kind of get to choose what goes in for those different pieces.
Thank you, Chris. Danette, if I could comment on that as well. So I've been very interested in the food justice movement and looking at eating from the social equity lens. And there's a few points we've always made is that McDonald's is not part of the traditional diet of any culture that I'm aware of. And I don't know of any traditional diet that's associated with obesity, including if you look back in the 1920s and 30s, what African Americans ate at home. First of all, there's a lot of home cooking. It was very high in plant-based foods, whole grains, and vegetables as well. So when you present that information to people, you say, well, wait a second, I'm not eating according to my traditions. And this applies, and not just to African American, it applies to everyone, Mexican Americans, anybody, even those groups that don't have high rates of obesity. We've all heard about Japanese Americans migrating to Hawaii and suffering the cardiovascular consequences. It puts things in a social equity lens. And I think Jim will tell you the fastest growing segment of plant-based dieters is African American now. And I think part of it is not just, well, if it's health, we need to get healthier. Part of it is looking at it through the social equity and food justice lenses as well. Okay, any last minute comments? So a couple of changes today. So as I mentioned, our first case presenter is not going to be available. So I'm going to present a case. And I've asked Adam and Danette to comment on it. Now, I would normally, Jim would provide a tremendous commentary for this case, but he, I believe, has seen the patient, not with me, but with a nurse practitioner I used to work with a few years ago. So I'd really like to hear Adam and Danette's insights, and then we can throw it open to Jim and to other folks. All right. Thanks very much, guys. Back to Claire for a moment.
Sure. Everyone should have a post-clinic survey in your email. We appreciate you taking a moment to fill that out to give us feedback on today's talk. And then I just wanted to make a comment. We do have an open case if anyone wants to present next week. Otherwise, we'll just do the same and present one case. And then for our last week is March 30th in 2 weeks. We are not going to do case presentations, but we are going to do more of like a question answer format. So if anyone has any questions for our speakers, subject experts, or update on your case that you presented, or really anything, if you can email me in advance, that would make it easier, but we will open it up the week of. So kind of start thinking about it. Email me if you think of anything. Otherwise, I will see everyone next week.
Thanks, everyone. Have a good week. Bye-bye.